Okay, so let's get started on part 2. This is week 2 out of a 6-week session. And I want to, whoops, I'm through it too fast here. Let's slow down a bit. Okay, I wanted to kind of review last week. We talked about the effects of caregiving, dynamics of the disease, stages of dementia, and I wanted to add a tour of the brain disease at this link. And when you get the PowerPoint, you should be able to get that link. ALZ.org Alzheimer's, they have a tour of the brain as that shows the progress of the disease through the brain. And it's a very interesting and very helpful to people who are caregivers. As a reminder, we talked about Maslow's hierarchy of needs. We talked about the effect of the disease. We indicated that the person who is diagnosed basically descends this chart down to basically physiological needs. And we also mentioned that corollary to the diagnosed descending this chart, the caregiver also descends this chart along with the care receiver. And the reason for that is that it becomes difficult to do things. For example, like having people over for dinner, when it becomes very difficult to do. So you stop having people come over for dinner. So in effect, the caregiver is also descending the Maslow's hierarchy of needs. We talked about the dynamics of the disease and the length of the disease. For example, on Lewy body, we talked about 3 to 8 years in terms of its duration, in terms of the disease. So the point of this particular chart was to indicate that we are talking about a long time or long-term process. We're not talking about something that's quick. We're not talking about 4 to 6 months. We're talking about a multi-year process of caregiving. And we need to be aware that this is a multi-year process of caregiving, and consequently, we need to take care of ourselves as caregivers. We talked about the stages, and we talked about how most people think of the disease as being a long, smooth arrow that goes from stage 0, basically, or stage 1 to stage 7 on that. And the reality of it is that the disease goes in plateaus. There's basically a set of behavior that takes place, and then one morning, one afternoon, one evening, the behavior changes, and you realize that they're now exhibiting behaviors that are in the next stage. On that. That doesn't mean that they just go to stage 3 totally. They're still having elements of stage 1, elements of stage 2, but they're adding new behaviors in this because of the progression of the disease. So you cannot predict when there's going to be a change in relation to the behavior of the person in relation to the disease. That's why decisions about driving and decisions of being home alone are paramount in terms of trying to figure out how to do that. Okay, and we talked about the diagnosis and understanding in the sense that Alzheimer's is, dementia is an umbrella term. Alzheimer's disease, quote unquote, the standard one that's diagnosed 65 when you're 65 and older, is approximately 60 to 70% of all dementia. Early onset, which we talked about and which my wife experienced, is approximately 5 to 6% of all people who have dementia. Parkinson's with dementia is about 50 to 80% of those with Parkinson, and Lewy body is about 5 to 10%, and there's a relationship between Lewy body and Parkinson. Frontal temporal dementia is about 2 to 5%, and vascular dementia is about 5 to 10%, and again, vascular dementia is based on strokes. Okay, we're going to kind of go through a bunch of statistics today, and in some respects, it's kind of, it's a little bit dry, but we'll try and get through it as best we can. And I think you'll find some interesting information in terms of comparison. What I've done is given you information and statistics about Oregon, but I've also added statistics about Virginia, so you can kind of see one, what the difference is, and number 2, what the commonalities are. Oregon currently has about 69,000 Oregonians with Alzheimer's, or about 1.6% of the residents. The number's expected to increase to around 84,000 by 2025, which is not very far from here. Currently, there are 545,000 Oregonians or 55 or older, approximately 12% have dementia on that. Over 188,000 are unpaid caregivers, and Oregon provides about $2.8 billion worth of unpaid care. In other words, if we extrapolated out the cost of caregiving, for example, on an hourly rate, and you're 24/7, you can multiply that out and you have a very large number. That translates into 2.7 caregivers. In other words, 188,000 caregivers over 69,000 people who have dementia. So that is interesting to me, because that means that one person cannot be the sole caregiver of the person for the lifetime of the disease. It's going to take more than one person to take care of that. And that is something that's hard to grapple with and hard to accept. Oregon's Medicaid cost alone is about $253 million. And again, the Medicaid cost is mostly to institutions, memory care, nursing homes, foster homes, and caregivers in the home. In Virginia, there currently is about 154,000 Virginians living with Alzheimer's, or about 1.8%. That's very close to the 1.6% of Oregon, and the residents out of 8.6 million. So Virginia is about twice as big as Oregon on that. The number is expected to increase to about 190,000 by 2025. And currently there is basically 1,894,000 Virginians are 55 and older, and about 7.9% or 154,000 are afflicted with Alzheimer's and related dementia. Over 349,000 unpaid caregivers in Virginia. They provide about $7.9 billion worth of unpaid care. That translates into 2.2 caregivers per diagnosed patient. Again, that means more than one person is going to be involved in the caregiving of a person who is diagnosed. So the caregiver needs to be aware that you cannot do it by yourself and be alone. Virginia's Medicaid cost alone is about $1 billion a year. And the Medicaid cost, again, goes mostly to those institutions and to the caregivers at home. In the US, 6 million are over the age of 65, 200,000 under the age of 65 have early onset, and that comes out to about 1.9% people with dementia. Sorry for what I did something and I shouldn't have done. I touched something. Sorry. The total population of 320 million. So in other words, the percent of people with dementia, of the total population is about 1.5 to 2%. Currently, 6.8% out of 90 million who are over 55 have Alzheimer's disease or related dementia. 1 in 10 people, in other words, of age 65 and older, 10.6% have Alzheimer's dementia. 1 in 3 seniors dies with Alzheimer's or other dementia. Almost 2/3 of Americans with Alzheimer's are women. Older African Americans are about twice as likely to have Alzheimer's, and Hispanics are about 1.5 times as likely to have Alzheimer's. It's not fully understood why there's that differential. Worldwide, currently there are about 50 million people worldwide with dementia, a little less than a little more than 0.5%. Currently, there are 617 million people that are over the age of 65, and roughly 8% of those have dementia. By 2030, there will be about 76 million worldwide with dementia. Average cost of care. For a total lifetime cost of care for someone with dementia, 70% is borne by families, either out of pocket or with long-term care expenses or from the value of unpaid care. A person with Alzheimer's disease lives between 4 to 8 years on average, although some may live more than 20 years. Again, a multi-year process. At home, professional caregivers generally are paid anywhere from $12 to $40 an hour. The rates depend on what the duties the caregiver may have to perform, such as housekeeping, cooking, dressing, bathing, etc. The more the caregiver does, the more money you have to pay per hour. Hospice general inpatient care, 24 hours, is at a rate of $743.55 per day, or roughly $22,300 per month. These are Medicare and Medicaid rates of payment. My experience was a bill for about $5,000 out of pocket for 4 months of hospice care in a facility. Some of that hospice was paid by my insurance. Twice daily visits and some services such as bathing were given in terms of hospice. The health insurance policy covered a major portion of this cost. In an Oregon facility where a person has Alzheimer's and related disease, moves to a nursing home to receive 24-hour care, the financial cost to the family is great. It's estimated right now currently at around $78,000 per year. It is estimated that the lifetime cost of care for a person with Alzheimer's is $156,000 a year. In other words, 2 years on average, 2 times 78,000 is 156,000. In a Virginia facility, the average cost of memory care facility in Fairfax County, Virginia, is approximately $84,000. It's estimated that a lifetime cost of care for a person with Alzheimer's is around $168,000. And again, Medicare doesn't pay much, and your insurance policy may not pay much. What was my experience? Fern Gardens, which was the name of the memory care, it has now been name changed to Table Rock Memory Care, Medford, is a memory care facility. Cost was about $4,900 per month, or $58,800 per year. Now remember that Nora was under the age of 65. And consequently, Medicare did not come in to help or pay any of this. It was all out of pocket. We add a doctor for $250 a month. We add support materials, diapers, hygiene products, medications. That's another $100 a month. And that comes up to approximately $4,200 per year. There's miscellaneous costs such as clothes, another $1,200 per year. So the total cost from my experience was $64,500 per year. This was total out of pocket. That's part of the reason I worked another 8 years, beyond what I thought would be a reasonable retirement date. Oregon was about $2,000 to $3,000 per month cheaper for memory care than Marin County, California. If we had not moved to Ashland, this would have added another $116,000 to $174,000 to the cost of care, or approximately $426,000 to $484,000 for the 58 months in which she was in memory care. Virginia's costs are more like Marin County, for a total cost of $440,000 for the 58 months. These costs do not include attorney costs for guardianship, which will be required by some memory care facilities. So you have attorney costs on top of that. Basically, you can see by this table that when Nora first went in, she was hostile to going into a facility. And so she basically had a single room, and the single room was $5,200 a month rather than $4,900 a month. As the disease progressed, that became less and less a problem in terms of having a roommate, and so she moved into a double, and that was $4,900 a month, and that's the difference between the single and double cost here. The doctor, I wanted a facility that had a doctor come by every week and basically do whatever the doctor wanted to do each week, and rather than have to take her out and take her to a doctor visit and so forth. Part of it was it kind of came with the facility, and I didn't think about it as being a requirement in picking a facility because, again, no experience about it. But when I'd gone through the experience, I really appreciated the fact that a doctor came to the facility each week. I found out in an unintended way that actually the doctor recommended hospice because the doctor had tracked Nora's weight for multiple weeks. And with a severe weight loss, as she was going through it, she went from basically 155 pounds to 120 pounds. The doctor felt that with continued weight loss, she was in jeopardy. And so he put her under hospice on that. Couple weeks into hospice, things turned around. She began to gain weight and she came out of hospice. But if I had been taking her out to a doctor, I probably would not have, nor would the doctor have noticed the weight loss, because I would not have been taking her out every week to see a doctor. It would have only been a doctor when something was going bad or something was going wrong on that. So the unintended consequence of having a doctor come to the facility was that Nora got better care than if I was responsible for taking her to the doctor. The other side of it is, as a caregiver, I really appreciated the fact that I did not have to take her out of the facility, take her to a doctor, go through that process and bring her back to the facility and, in a sense, drop her off on that. Are there any questions at this point? I noticed some things in chat.
Yes, this is just an exchange about the slides. So
Okay.
No questions so far.
Okay. Full service memory care, the average stay is around 24 months. However, there are a lot of variables in the length of stay, to name a few. Why do I even go over how long stay is average, for example, for memory care? Well, because I've been trying to plan my finances out when this was going on. I wanted to kind of know how long is she going to be in memory care? How much money am I going to need to take care of her in memory care and so forth? So this was all pieces of information into me for planning on this process and planning on how it's going to affect me. And again, remember, it's a multi-year process, which means that if the rates go up and continue to go up, then each year I'm going to have an increase in expense. So for planning purposes, it was good to know this information. So the average stay is around 24 months. However, there are a lot of variables in the stay. The type of dementia and how fast it is progressing. For example, early onset Alzheimer's is a 4 to 8 year span, so to speak. Standard Alzheimer's was 15 to 25 years. So that's a big difference in terms of looking at the problem and looking at what's going to happen on that. Physical shape of the person at the time of placement. Are they in good shape? Or are they in poor shape? Do they have additional ailments such as diabetes, cancer, COPD, etc. on that? What stage of the disease when the person is placed? Is it the early stage, middle, or late stage? And what are the advanced directive instructions and adherence, such as does it direct the person to not prolong the illness by stopping certain medications, such as statins, anti-cholesterol, insulin, Aricept, and so forth? My experience was that over 65 diagnosed with Alzheimer's disease, Dylan, well, these are people out of the support group, Dylan placed his wife, and in 4 months, his wife passed. Betty placed her husband, and a little over a year, her husband passed. Under 65, I diagnosed with Alzheimer's. I placed my wife for 4 years and 10 months before she passed. If you add that up, so to speak, 73 months divided by 3, you come out with 24.6, approximately the average stay of 24 months. So it really depends on those variables in relation to the placement in terms of how long are they going to be placed on that. Sources of funds for caregiving: personal wages, salary, investments, retirement funds, real estate, savings. Basically, I went through all those. When I was taking care of Nora and paying out of pocket, I basically went through all my investments. I went through the 401k that we had. I went through my stock purchase options. I went through in the real estate. We sold a house and I took the equity out of the sale of the house to help pay for the process. I was making an extremely good income in information technology during this process, but when the process went on into the 4th year, I was getting very close to having to go to Medicare and Medicaid for help and assistance in paying. Medicare, as we all know, is a federal health insurance program for people 65 and older. People under 65 or even over 65 can receive Social Security disability payments for at least 24 months. Medicare covers inpatient hospital care and some doctor fees. Medicare Part D pays for the prescription drugs. Medicare will pay for up to 100 days of skilled nursing home care under limited circumstances. However, custodial long-term nursing home care is not covered. Remember, we're talking a multi-year process. So even though Medicare may pay for 100 days of skilled nursing, that's not going to cover a lot of the expense. Medicare will pay for hospice care delivered in the home, a nursing facility, or an inpatient hospice facility. And the Medicare special needs plans available for individuals with dementia includes Alzheimer's disease. These special need plans are Medicare Advantage plans that specialize in care and coverage for beneficiaries with dementia. Only Medicare beneficiaries with dementia can enroll in these plans. Nora was not part of Medicare. She wasn't over 65. So these plans did not apply to her. Medicaid. Medicaid is a federal state program typically administered by each state's welfare agency. Eligibility and benefits vary from state to state. If the person with dementia is eligible for supplemental security income insurance, he or she is automatically eligible for Medicaid. Those not on supplemental Social Security income must have a limited income and assets. The amount is determined by each state. This is where it's very important to get together with a lawyer, especially in the beginning. When we talk about the diagnosis, this will be one of the things that we will go over. But Medicaid and being eligible for Medicaid is an extremely complex and difficult issue. It is not simply going down to the administrator and standing in front of his or her desk and saying, I qualify, and here's the reason I qualify. Medicaid has a 5-year look back. So you have to make sure your financial situation is structured in such a way that a 5-year look back will not disqualify you. For example, if you sold your house and gave all the proceeds to your children and then walked into the administrator and said, gee, I'm broke, the 5-year look back would say, well, what happened to the equity that you got in the house? And they would say, go to your children and get the equity back on that. Medicaid and long-term care, Obamacare. Obamacare was the extension of Medicaid. If they had repealed Obamacare, Medicaid would not have paid for nursing homes for dementia. That was written specifically into the Medicaid extension in Obamacare. And remember that Obamacare was not repealed because of John McCain's vote. That one vote in the Senate kept Obamacare and kept Medicaid and kept the ability of Medicaid to pay for long-term care. How to apply for Medicaid? You have to apply information that is where you live, family members, your monthly income, your property, your belongings, your savings, your investments, your medical expenses. Most nursing homes that accept Medicaid will have staff who can assist in applying for this. And there is also a concept, in addition to Medicaid, called preservation of spousal assets. This is another one where you need to go to a lawyer and talk to a lawyer. Preservation of spousal assets in Oregon is where you can take your assets and split them in half if you're married, for example. So I would have half my assets, she would have half the assets. That would include income, for example. You can spend down her half of the assets. And once she reached a certain point in spending down her assets, she might qualify for Medicaid. They would not look at your half of the assets. They would look at her half of the assets in terms of the ability to pay. So there is this concept of preservation of spousal assets. It's not well known, and it's not, in a sense, highly advertised. However, if you go to an attorney, an estate attorney, they are familiar with preservation of spousal assets, and you can go and get your financial situation structured in such a way that that becomes a possibility. I had talked to the attorneys in the fourth year about preservation of spousal assets to try and structure myself so that when I ran out of assets, which would have been in about 3 to 6 months after she passed, if she had lived that long, then I would have been in a position to be able to have her half qualify for Medicaid so that we could get some relief in relation to that. As the process went along, my stress level on finances was increasing very quickly. Another source of funds is family. Children may help to pay the costs of the care of their parents. Complications arise, though, when there is a divorce and the children are associated with one spouse or the other. In the support group, there were occasions where stepchildren would provide absolutely no assistance to the stepmother or stepfather. They felt that that was the responsibility of their mother or father in the relationship. In other cases, the stepchildren would harass, in a sense, the partner who was taking care of their parent because they felt that she or he was not doing a good enough job of taking care of their parent. I saw this in the support group on multiple occasions, where the mother who had stepchildren not only had to take care of the father, but also had to deal with stepchildren who were complaining about how she was taking care of their father. It's not common for relatives such as parents, grandparents, aunts, or uncles to help pay for caregiving. Most of their help comes in the form of no-cost caregiving on that. Friends. It is uncommon for a friend of the family to financially help support the caregiving costs of the family. In other words, they're not really a source of funds to help pay for the care of the person. In the family, that also is true in most of the cases, that the extended family is not quite capable. Most of the support from a friend is occasionally substituting for caregiving at no cost. An example of this is where when I was telecommuting at the time, and when I went down to San Francisco from Ashland, I would bring Nora with me. This is before I placed her. I would bring Nora with me, and I had a friend of hers, a very dear friend of hers, who would come and take care of her while I would go in and basically have meetings and meet with my boss and do the job on that. About the third time this occurred, I came back from work about 5 o'clock, and there she was sitting in the lobby just by herself. And person at the desk told me that she had been there since about 4:30, just sitting there. And I felt relieved in the sense that I had told the people at the motel that we were staying at that she had dementia, and they helped me out by kind of watching her in that situation. But what I found out was that her friend, it was too difficult to take care of her. It was too hard for her to take care of her on the third occasion. It was too disruptive to her and too stressful for her, so she couldn't deal with it. And that's part of the problem with friends. If we rely on friends a lot, we may burn our friends out in terms of caregiving. And so it's a major issue. What are the various roles of the caregivers, from in-home care agencies to social workers? In-home care agencies, let me stop and ask, are there any questions at this point?
Yes, quite a few.
Okay.
Jerry asks, what criteria indicate the need for memory care out of the home? How much service can be brought in to keep the person at home?
It's a complex answer to that. You didn't intend it, but I'm going to make it. What I found in my own experience was that at some point you're going to need 24/7 care. You cannot do 24/7 care by yourself. And so the cost of 24/7 care is really going to come up to about equal of memory care and possibly even more than memory care. If you're up in the approaching $40 an hour, then you're going to be paying more for people in the home than you're going to be than memory care. The other issue is that the longer you keep them in the home, the higher your stress level goes, because as they basically go down Maslow's hierarchy of needs, your need to take care of them increases. And so it's not like something that is diminishing, it's like something that is increasing over time. So as they become more disabled, so to speak, you become more important to their care. And so I'm basically going to do a sidebar. When the person is diagnosed, and you'll hear this again when we talk about diagnosis, when the person is diagnosed, the care receiver and the caregiver should really talk to each other and set out objective criteria for placement. In other words, mine was incontinence. If she became incontinent in the home, I would place her regardless of what stage she was in, because I was not going to deal with diapers, and I wasn't going to deal with trying to clean her up if things became messy on that. And my view is that you set this objective criteria, and if the person who is diagnosed crosses that criteria, then you look to place them. Part of the reason why you should place them, in my view, if you can have the resources to do it, part of the reason for placing them is then you can move back up the Maslow's hierarchy of needs. They will take care of them. They will take better care of them than you will. And so you would then be free to begin to take care of yourself on that. So it's a complex answer in terms of when do you have them come into the home and so forth. The issue is, how is the caregiver? If the caregiver is angry, then you need help. If the caregiver is running out of gas, so to speak, in caregiving, then you need the help. I would look to how the caregiver is doing, not how the care receiver is doing, in terms of how much help I need in the home. I hope that answers your question. It's long-winded. Any other questions?
Yes, the next question is from Louise. I believe you mostly answered it, but just in case if you have some more thoughts. My sister-in-law has Alzheimer's and is in memory care. We were advised to hire an elder care attorney. What is your experience with an elder care attorney, if any?
I would think that you would need to sit down with the attorney to make sure that the financial structure is such that when the person passes, you are in the best situation you can be in terms of your financial structure. Secondly, is that if the cost of the memory care is going to potentially wind up in Medicaid, I would definitely talk to the attorney to get yourself structured in such a way so that when it comes time for Medicaid and applying for Medicaid, you're already set to go. You have all of your financial structure in place and ready to go on that. I found that I had to go to court twice during the home care situation, not home care, during the memory care situation. One, because they weren't following her advance directive, and I went to go get basically a judgment to tell them to follow it. And the second was that I needed to change a beneficiary on a company policy, and they would not accept the fact that I had guardianship as being the basis for changing that beneficiary. They needed her signature. She was not capable of that signature, so I had to go to court, very briefly, to have the court approve changing the beneficiary of a policy. And we'll talk a little more about that later. So my view would be is make sure that you touch base with an attorney, elder care attorney, to make sure that your financial structure is pretty much in place.
Okay, thank you. Next one. I guess you answered that too. Were you able to keep your job when you moved from California to Oregon, or did you have to find a new job in those trying circumstances?
I have to sing the praise. I know most people have mixed views of Wells Fargo Bank, but I have to sing the praise of Wells Fargo Bank. When I told them that my wife had Alzheimer's and told them that I think we needed to move to Oregon, they permitted me to telecommute before COVID hit. And this was back in 2011 when we moved up to Ashland. And so I telecommuted, and that's when I had to go down every once in a while. Usually once a month, I would go down to the Bay Area and visit with my boss and others there. But I was capable of telecommuting, and they were quite okay with that. And but that was, to me, was a tremendous benefit from Wells Fargo. They were very understanding. And part of that understanding came from the fact that I was capable of talking with them about my situation and what was going on. And they had empathy and care about that situation so that they understood what was going on.
Oh, thank you. Next one. Can you discuss long-term care health insurance for caregiving?
Yeah, yes. I took out long-term care health insurance in 1995 when I joined Wells Fargo. And I took out the family policy. In 2009, when she was diagnosed with Alzheimer's, I went back to that policy and looked at it. And there was a paragraph. There was actually a footnote, a fine print footnote at the bottom of a page that said for her to qualify for long-term care on the family policy, she had to apply separately. I had not seen that and did not do that. That was my fault, my issue, my problem. And I knew that once she had the diagnosis, there was no way that they would approve her being part of the policy on that. So two things about long-term care. Yes, it helps, but read the fine print and make sure that you are qualified and that what they don't cover and what their exceptions are don't deal with dementia or don't deal with memory care facilities. In other words, make sure that one, they're eligible, and number two, how much help are they going to provide? It would have been extremely helpful to me if they had provided, because they would have provided about $1,500 a month in her care if everything had worked properly. And again, that was on me. That was not on the insurance company. That was on me.
Thank you. Next question. Is it better to have elder care lawyer than an estate lawyer, or do I need both?
Either one. It doesn't, the two are the same.
Okay, thank you. That's it at this point.
Okay, thank you. In-home care agencies is primarily engaged in providing in-home care services. In-home care agencies are not home health agencies. They do not provide home health services, at least in Oregon. In-home care services are personal care services furnished by agencies and arranged and contracted with an in-home care agency. They are necessary to assist an individual in meeting the individual's daily needs, but they do not include curative or rehabilitative services. If they do, well, I'll get to that in a minute. They must be licensed as an in-home care agency. And if you're doing one or more of the following, if you're scheduling caregivers, assigning work, assigning compensation rates, defining work conditions, or negotiating for a caregiver or client, then in a sense, you are providing in-home care agency. What type of services do in-home care agencies provide? If they do provide, they provide bathing, personal grooming, dressing, toiletrying, elimination, mobility, movement, nutrition, hydration, feeding, housekeeping, laundry, shopping, transportation, arranging for medical appointments. All that, as you can see, is going to go towards the $40 an hour, not to the $12 an hour. In-home care agencies may also provide medication and nursing services, but these services require additional conditions for approval. And again, these conditions include additional policies and procedures and primarily a nurse on staff. So you would be up into the higher ranges of that. That's why I say that if you're having all this being done by a in-home care person, I would really evaluate the cost of the in-home care versus the cost of memory care. And again, one of the things you have to factor into that cost is that in memory care, in a sense, you are not the primary responsibility for caring for that person. Consequently, you will begin to have your life back. If you keep them in the home, you do not have your life back. A social worker, one aspect that all of social work has in common is the intake and initial examination of both the client and their situation. This includes many levels. In the case of social work in a medical or counseling environment, they may determine what was the best course of action to take care of the person. When a client is in crisis, the social care worker's job is to effectively evaluate the client themselves and also the person who is capable of taking care of it. This is the analysis that helps the social worker to understand what interventions will be most effective to aid the client. Sometimes it's a matter of connecting a client with resources. In other cases, it might be connecting it with a medical or mental health care. Social work can also take the form of acting as a counseling capacity on that. You also have personal consultants and social workers. Most personal consultants are trained social workers or psychologists. Most of the time, from what I saw and from facilitating caregiving support groups, the consultants tend to represent the person diagnosed. What do I mean by that? When you have a personal consultant to come in and help you, they tend to take the position of speaking for the person who is diagnosed. And one of their views is to try and keep that person who is diagnosed in the home as long as possible. What I'm trying to say is, in nice terms, but I'll be more straightforward, is at times taking the position of the diagnosed is detrimental to the welfare of the caregiver. If the caregiver has run out of gas with caregiving, then you need to help the caregiver more than you need to help the diagnosed. They become the care receiver's advocate, and they also are compensated and have a consultant fee associated with their work. In other words, they're not free and they're not cheap. In Oregon, for example, and I've worked with both of these people, Maria Kane and Elizabeth Hallett, are the personal consultants who work with people and have a very good understanding. These people are very competent, very good understanding of what's going on with dementia and what's going on with the process of people who have dementia. On that, they can support the caregivers and the care receivers, and they can work with the family, and they can be very helpful in working with the family to find a place to place the person. Examples of personal consultants in Virginia is Elder Care Consultants. Elder Care Consultants is actually providing dementia education and care on this. And they are primarily, I think, state sponsored on this. They take a person-centered approach, a philosophy of care built around the needs of the individual. The person-centered care is the underlying philosophy of the Alzheimer's Association Dementia Care Practice Recommendations. Lionheart Elder Care and Consulting. We never forget that everyone has unique emotions and values. We support you in making important decisions about your life calmly and effectively on that. So these two are doing, in a sense, the same thing that Maria Kane and Elizabeth Hallett are doing in Oregon. And that is to work with the family, work with the person to deal with the issue of dementia and to help them work out a plan for how to deal with the long-term issues and long-term care on this. Again, elder care consultants are not lawyers. They are social workers. They are psychologists and so forth. On that. Hospice. Hospice offers medical care toward a different goal, maintaining and improving quality of life for someone whose illness or disease is unlikely to be cured. Each patient's individualized care plan is updated as needed. Hospice care offers practical support for the caregivers, and hospice is something more that is available to the patient and the entire family when curative measures have been exhausted. The vast majority of hospices follow Medicare requirements to provide the following to manage the illness. Time and services of the care team, including visits to the patient's location. Hospice visited multiple times a day to Nora when she was on hospice. They provide medication for symptom control and pain relief. In other words, they will provide palliative care. They will provide medication to make the person comfortable. They will not provide medication to cure the person on that. Medical equipment like wheelchairs and walkers and medical supplies. They have physical and occupational therapy. They have speech language. These are people who have strokes, for example. Dietary counseling and other Medicare services needed to manage the pain and symptoms. Short-term inpatient care where adequate pain and symptom management cannot be achieved in the home setting. In other words, if you cannot provide adequate pain and symptom management in the home, then they will try and put them into an inpatient care process. Short-term respite care, temporary relief from caregiving to avoid caregiver burnout. In other words, they will work with the caregiver to provide support for the person while the caregiver may go out to a movie or go out and do things that would improve their life. And they also provide grief and loss counseling for patients and loved ones. What's not covered? Not all services provided to patients enrolled in hospice care are covered by Medicare hospice benefit. Treatment intended to cure your terminal illness or unrelated illness is not covered. Prescription drugs to cure your illness is not covered. Room and board in a nursing home or hospice residential facility is not covered. Care in emergency room, inpatient care, ambulance transportation is not covered. In other words, hospice is there for palliative care and to make the person who is within 6 months of passing or shorter comfortable and basically anxiety-free as much as possible. Family and friends. 83% of the help provided to older adults in the United States comes from family members. Nearly half of all caregivers who provide help to older adults do so for someone with Alzheimer's or dementia. Who are the caregivers? About 1 in 3 caregivers is 65 or over. Approximately 2/3 of caregivers are women. Over 1/3 of dementia caregivers are daughters. Approximately 1/4 of dementia caregivers are a sandwich generation. What does that mean? That means that a daughter, for example, may have kids at home, and they may have a parent living with them who has dementia, and that's called the sandwich generation. My wife's daughter is in that exact same situation. Her father is in the home. She has 2 children that are 12 and 8. And she is taking care, in a sense, of both ends of the spectrum on that. It's very, very difficult. Alzheimer's takes a devastating toll on caregivers. Compared with caregivers of people without dementia, twice as many caregivers with dementia indicate substantial emotional, financial, and physical difficulties. According to a report from the National Consensus Development Conference on Caregiving, the most common psychological symptoms of caregiver syndrome are depression, anxiety, and anger. Peter Vitaliano, a professor of geriatric psychiatry at the University of Washington, said that chronic stress of caring for someone can lead to high blood pressure, diabetes, and a compromised immune system. In severe cases, caregivers can take on the symptoms of the person they're caring for. For example, a person caring for someone with dementia may develop progressive memory loss. Worse still, the syndrome can lead to death. Stanford University study reports that 41% of Alzheimer's disease caregivers die from the stress-related disorders before the patient dies. That's an astounding figure. 4 out of 10 caregivers pass before the person they're taking care of. And that's why, in part, I put this course together. And that's also in part why I keep emphasizing that we need to keep track and take care of the caregiver so that the caregiver can survive this process. Caregivers have a 63% higher mortality rate than non-caregivers. According to the report by researchers at the CDC and Georgia State University, 53,000 people died from Alzheimer's in the United States, compared in 2014, a 54% increase compared with 1999. Now, part of that is because in the early periods, 1999 and so forth, they may not have put down dementia or Alzheimer's as the cause of death. They may have put down pneumonia and all that. So as they're putting more, being more accurate about why the cause of death, in other words, Alzheimer's, on my wife's death certificates, they indicated death due to Alzheimer's on that. I think that's the reason for the 54% increase. During that period, the percentage of people who died from Alzheimer's in a medical facility fell by more than half. Again, I would say part of that is due to the fact of cost. Meanwhile, the number of people with Alzheimer's who die at home increased by 24%. The remainder passed under hospice care, 42%, or in a non-medical facility, such as a foster home or memory care. Any questions before we get into the Ombudsman?
Not at this point.
Okay. Why do I bring up Ombudsman? Well, there's a good reason I bring up Ombudsman. One is that one of the reasons I went to court was because an ombudsman interfered, so in my view, interfered in how they were taking care of Nora on that. Now, I want to say right out in the beginning, I think the ombudsman and the ombudsman organizations in Oregon and Virginia are absolutely critical and important. What's their role? Their role is to prevent elder abuse and to make sure that the facilities are following the rules and regulations of the state and are taking proper care of people on that. They do a fantastic job. The problem is that there is a discrepancy in ombudsman and advanced directives. Ombudsmen do not necessarily take into account advanced directives. So long-term care ombudsman program is an independent state agency that serves long-term care facility residents, and they investigate complaints, they advocate resolutions and improvement in residential care. The vision of the long-term care ombudsman is that Oregon citizens, this is Oregon's, living in nursing homes, residential care facilities, assisted living facilities, and adult foster care homes deserve quality care. They should be free from abuse and neglect and the freedom to make choices about their care. The mission of Oregon's long-term care ombudsman program is to protect individual rights, enhance quality of life, improve care, and promote dignity of residents living in Oregon. The program staff work with a statewide network of over 180 volunteers who work in their own communities in a variety of roles. In other words, the ombudsman is a volunteer, but they're in a state agency organization. The services of the long-term care ombudsman program are free and available to residents, families, facilities, facility staff, and so forth. The ombudsman respond to a wide variety of resident concerns, including problems with resident care, medications, billing, meal quality, evictions, guardianships, dignity, and care programs. The ombudsman programs serve residents in nursing facilities, residential care facilities, assisted living facilities, continuing care facilities, and adult foster care homes. And complaints are investigated and resolved by staff and trained and certified volunteer ombudsmen. Beyond the complaint investigation, ombudsmen strive to be the eyes and ears of residents and advocates to improve the quality of care of a person in a facility. They provide an important function. There's also residential ombudsmen in the state of Oregon. And these are people who basically will come into your home and will basically review how things are going on in the home. Primarily, what starts their process is a complaint. If there's a complaint about elder abuse in the home, then a residential facilities ombudsman will come into the home and make an evaluation. The residential facility ombudsman program began visiting homes in Eastern Oregon counties in July of 2016. So it's a relatively recent program. They revisited 100% of the homes in more than 16 counties, providing community outreach, responding to requests of assistance. The goal is to visit 100% of the homes in 8 additional counties. And that is homes that have people who are being cared for. When we're not visiting individuals in their homes, they're opening services in new areas. The residential program is part of an independent state agency that is resident rights and client driven. They're free and confidential. Oregon also has a public guardian and conservator program. In other words, if you're by yourself and have no one to be a guardian, there's a public agency that will provide guardianship for you and conservatorship for you. It's court appointed, and they're surrogate decision makers for adults incapable of making most of the decisions. Where guardianship is the only option to make a person safe, the Oregon Public Guardian and Conservator Program will become involved only if there's no other responsible person willing or able to serve. So it's basically the substitute. The guardianship is one of the most severe restrictions on a person's right to self-determination. Under guardianship, a person loses the right to make their own decisions about their lives. Guardianship should only be considered as an option if other less restrictive alternatives have been attempted. And I found in my circumstance, the memory care facility that I placed Nora in required a guardianship. In the state of Virginia, Ombudsman advocate for older persons receiving long-term care services, where the care is provided in a nursing home, assisted facility, or through community-based services. This is the state of Virginia's long-term care and residential. We provide older Virginians and families and the public with information, advocacy, and assistance to help resolve care problems. We work to resolve problems of individual residents and groups. The cornerstone of this work is the residents' rights. While many people receive good long-term care services, others encounter problems and neglect. The Ombudsman program also has advocates that assist individuals who are participants in the Commonwealth Coordinated Care Plus program. Medicaid managed care advocates help to resolve problems with plan coverage, assessing plan benefits, and health services. Long-term care ombudsman state agency also covers residential facilities. So in the state of Virginia, they're a little different than the Oregon in terms of structure. Their ombudsman organization in the state of Virginia covers facilities as well as the home within one organization. In Oregon, they have, in a sense, two organizations, one for facilities and one for the homes. Public Guardian and Conservator program in Virginia. Virginia has a similar program as Oregon. The state has the capability of selecting a guardian or conservator, such as a person, when an individual such as a person diagnosed with Alzheimer's or dementia has no one capable or wanting to become their guardian or conservator. One thing to note here is, like Oregon, Virginia's court appoints the department agency, not an individual. In other words, the department has been appointed as guardian, not an individual within the department. It is the responsibility of the department to act as a guardian or conservator for the person on that. That means that you may be dealing with different people within that department when there is a guardianship issue. Okay. Are there any questions at this point before we start our next session?
Yes, there are a couple. What's the difference between nursing home and memory care?
Say that again, please.
What's the difference between nursing home and memory care home?
In my view, big difference. Memory care generally is in a facility that has been designed for people with memory care issues. In other words, it's a lockdown facility. The doors are locked. The person who is diagnosed and in a memory care facility cannot get out without assistance from somebody who works there on that. In a nursing home, they're not lockdown facilities. And in fact, I'll give you an example. In a support group, a person, and this goes with foster homes as well. A person had to place their wife. They placed the wife in a foster home. The foster home was not geared to memory care. She didn't want to be there, so she constantly walked around trying to find ways to basically leave. She would walk out the doors, and they finally had to change the locks and the way the doors were on the foster home. She would go to the fence and find ways to get out of the fence and so forth. And so they had to change the structure of that. Foster homes and nursing homes are not geared to the kinds of problems that a memory care facility encounters. Wandering, leaving, and also being hostile. You can find people in memory care who become hostile and angry. And memory care people are trained to deal with that and know how to deal with that issue. In many cases, foster homes and nursing homes, they're not equipped to deal with people who become hostile. And so from my perspective is that if you're going to place a person with dementia, I would place them in memory care because it's safer for them. Think of it as being safe for them. That foster home for the woman who tried to get out was not safe for her. She was not in a good place. And so, again, if you have the choice, I would take memory care over a nursing home. And I wouldn't really listen to the people in the nursing home saying, oh, that they can deal with it and they can take care of it and so forth, because they really do not experience the same problems that you experience in a memory care facility.
Thank you. There are a couple comments also in the chat.
Okay.
Fred writes, Fairfax County has an excellent ombudsman program, and I'm currently an ombudsman and an assisted living facility in the county. So the next one is from Joyce. Medicare hospice plan is available for those not thriving anymore, not just for the dying.
Okay, good. Those are good programs. And thank you to the Ombudsman.
Yeah, thank you. That's no more at this point.
Okay. What I'm going to do, because we have about 15 minutes left, I'm going to start the session 3, but when I send out the PowerPoints, I'm only going to send out the PowerPoint that we went over today and not 3, because I want to go through 3 first before we start to go through, before I send it out to you. So if you don't mind, I'm going to stop sharing for a moment, and then I'll come up with a new program, a new okay, can you see all that? Are we okay?
Yes, caregiving and dementia, part 3.
Mr. Harris, can you please click that little screen icon down in the lower right corner? It'll give us a better view.
I apologize. We tried that before. We have an issue with Bill's computer.
Okay, thanks.
I can click it, but it's not going to.
Yeah.
Okay, you tried. Thanks.
Okay. I try to be helpful. Again, I send this out to you, so if you have some problems with reading some of it, you can reread it, so to speak, when you receive it. Okay, we're going to talk about diagnosis and action items this week and next. We're going to be at basically something is wrong, diagnosis, and understanding and reacting to the diagnosis. Why do I even bring up the idea that I know something is wrong? The reason I bring this up is because that was Nora. Nora complained in 2000, 2001, and then again in 2008, that there was something wrong. Something was not right. And I did not pay attention to that. I did not accept that as something fundamental. I basically said, that's just part of aging. Don't worry about it. It's going to go away. Things will be fine, and so forth and so on. And it turned out that she was absolutely correct. There was something wrong. And so what's the point of this? The point of this is when someone comes up to you and says, I know something is wrong. I'm having trouble with my memory. Believe them. Accept it as a fact. have them take the test. Have them take the neuropsychological test. That will tell them if there is something wrong or not. And there's nothing wrong with taking the test and finding out that there's nothing wrong. In fact, that's a good day on that. But the reason I point this out is we have a tendency to minimize and discount when a person says, I know something is wrong. So I'm pointing this out to believe it. My wife knew something was wrong in the early 2000s when she could not figure out how to redesign the library reference desk configuration. They were redesigning the library desk configuration in her branch library, and she could not put it together. This caused her to resign as head librarian of the branch, and it was her decision and not management's, because she knew something was wrong, and I did not pay attention. I did not deal with that. And I still feel bad about that. Many people take little memory lapses and think they're getting Alzheimer's or dementia. The critical part here, memory loss that disrupts daily life, and that's the key, disrupts daily life, may be a symptoms of Alzheimer's or another dementia. Alzheimer's is a brain disease that causes a slow decline in memory, thinking, and reasoning skills. There are 10 warning signs and symptoms. Every individual may experience one or more of these signs in a different degree. Memory loss that disrupts daily life. One of the most common signs of Alzheimer's is memory loss. But remember, some of the dementias we talked about, memory loss is not an issue. For example, in Lewy body. Lewy body, memory loss comes later. What you have in Lewy body is a loss of the ability to design a reference library desk. Others include forgetting dates and events, asking for the same information over and over, increasingly needing to rely on memory aids, and etc. What's a typical age-related change? Sometimes forgetting names or appointments, but remembering them later. Another indication or warning sign is challenges in planning or solving problems. Some people may experience changes in their ability to develop and follow a plan or work with numbers. They may have trouble following a familiar recipe or keeping track of monthly bills. What's a typical age-related change? Making occasional errors when balancing a checkbook. I remember my wife one time spent 3 days trying to balance the checkbook. When she got finished, I looked at the balance she came up with, I looked at the balance the bank had, and they were not even close. She could not balance the checkbook on that. Difficulty completing familiar tasks at home, at work, or at leisure. People with Alzheimer's often find it hard to complete daily tasks. Sometimes people may have trouble driving to a familiar location, managing a budget at work, or remembering the rules of a favorite game. What's an age-typical related change? Occasionally needing help to use the settings on our microwave or to record a television show. We all, I think, can attest to the remote issue. Confusion with time and place. People with Alzheimer's can lose track of dates, seasons, and manage a passage of time. They may have trouble understanding something if it is not happening immediately. And sometimes they may forget where they are and how they got there. Getting confused about the day of the week, but figuring it out later is a typical age-related change. Trouble understanding visual images and spatial relationships. For some people, having vision problems is a sign of Alzheimer's. They may have difficulty reading, judging distance, determining color or contrast, which may cause problems with driving. Vision changes related to cataracts may be a typical age-related change. New problems with words or speaking or writing. People with Alzheimer's may have trouble following or joining a conversation. They may stop in the middle of a conversation and have no idea how to continue, or they may repeat themselves. They may struggle with vocabulary, finding the right words, calling things by the wrong name. Age-related, sometimes having trouble finding the right word. Misplacing things and losing the ability to retrace steps. A person with Alzheimer's disease may put things in unusual places. They may lose things and be unable to track their steps to find them again. Sometimes they may accuse others of stealing. This may occur more frequently over time. Misplacing things from time to time and retracing steps to find them are typical age-related. Decreased or poor judgment. People with Alzheimer's may experience changes in judgment and decision-making. For example, they may use poor judgment when dealing with money, giving large amounts to telemarketers. They may pay less attention to grooming or keeping themselves clean. What's a typical age-related change? Making a bad decision once in a while. Nora could not tell a telemarketer who was with a charitable organization no. Every time they called, she would donate money. I finally had to take the credit card away from her because she could not say no over the phone. Withdrawal from work or social activities. A person with Alzheimer's may start to remove themselves from hobbies, social activities, work project, or sports. They may have trouble keeping up with their favorite sports teams or remembering how to complete a favorite hobby. Age-related, sometimes feeling weary of work, family, and social obligations. And changes in mood and personality. The mood and personalities of people with Alzheimer's can change. They can become confused, suspicious, depressed, fearful, or anxious. Age-related, developing very specific ways of doing things and becoming irritable when a routine is disrupted. This is just a simple chart kind of going over what we just went over. Poor judgment and decision-making, making a bad decision once in a while. Inability to manage a budget, missing a monthly payment. Losing track of the date or season, forgetting which day it is and remembering later. Difficulty with a conversation, sometimes forgetting what word to use. Misplacing things and being unable to retrace steps to find them, and losing things from time to time. What's important here is it is your daily life. If it is interfering with your daily life, then it may be an indication of dementia in relation to it. If it's occasional things that are not interfering with your daily life, it may be just an age-related change, or as my brother likes to say, a junior moment. Okay. Any questions at this point?
No. Hold on just a second. I'm scrolling up. How do you know where to take away responsibilities like balancing the checkbook?
I have to smile at that because my wife couldn't balance the checkbook. So that was a clear indication it should be taken away. That is, in a way, it's a very interesting and important question, because that is what most of the caregivers deal with most of the time and have the most difficulty with, and that is, when do I take a capability away? We're going to talk about that when we get to what I call hard decisions, such as driving, such as traveling, such as going to events. The caregiver is going to be constantly dealing with those issues of when do I take some capability away. And part of the issue with that is that the caregiver will feel bad about taking a capability away. Guilt will come into play on the caregiver's side because I took something away that they really enjoyed, or at least I thought they enjoyed. One of the things I want to point out in terms of these signs of dementia and whatnot, and it's not very commonly understood from my point of view, And that is, it's not just memory loss. It is judgment loss. It is understanding the relationship of where I am in my environment and what is going on. They are losing the capability to be what I call rational. They may speak in sentences, they may speak in paragraphs, they make a lot of sense and so forth, but they may not be rational. They may not be making a good decision. For example, many cases, the people, especially in the early stages, they will enter what I call the elder twos. And that is that whenever you suggest to do something, such as, we need to move to a smaller house because it's too big and I can't take care of it, and you say, well, I want to sell the house. Their answer is going to be no. You say, well, we can't, the car's not being used. Let's sell the car. No. They get into the terrible twos. Everything you want to do to change something in their life is a no. And so you have to begin to understand that you are the one making the decision, not them. You are the one who's going to decide X, not them. And I saw many, many times in the support group where the people tried to develop consensus, tried to make sure that the other person understood why they were making a decision. And they were not successful. They were not very successful in doing that. And that's why I came up with, in effect, stealing from Nike, just do it. When you have to downsize your house because you can't handle both, that's your decision, not a communal decision. It's tough, it's hard, it's fraught with guilt, but that's what you have to do. That's what you have to do to take care of yourself. Go back to that Stanford study. 4 out of 10 people passed before the person they were taking care of. Part of the reason they passed is they didn't take care of themselves. The stress overwhelmed them. And part of the definition of stress is not doing the things that you know you should be doing. All right. Okay, well, it's almost 10:15, or that's West Coast time. Let's say 1:15 for the East Coast.
Yes.
And by the way, good luck with the hurricane that's going to be blowing through there. And I want to thank you again for attending, and we will complete this section next week. And I will be sending out the PowerPoint 2, the second PowerPoint to you through the login at the Ollie, and Michelle has indicated that she would pass on that information to you. All you have to do is send her an email that you would like to have the PowerPoint on that. I want to thank you again.
Question.
Yes.
Michelle, how do I get to you? I definitely want to get this information. And do you have my email? I was in the other session that was had a while back. Do you still have all of my information? My name is Van Jewel Graham.
You're on mute, Michelle.
Sorry. Are you a member of Ollie?
No.
Okay, then do this.
I was with Mason Care.
Perfect.
Before.
Perfect. Send me an email. That's all you have to do. My email is in the chat. Can you even see the chat?
No.
Oh dear. Okay. Can I go ahead and give my email verbally?
Sure, you can give it to me.
Can you do that offline?
I'm not sure.
I'm not sure either.
Okay,
Yeah.
well, go ahead. We'll just turn our head so we don't listen.
No. Everybody can have it. It doesn't matter.
Okay.
Okay. Pencil and paper. Everybody ready? Okay.
Yes.
Okay. 2 facts 2. That's T as in Tom, U as in university, V as in TU, F as in Frank, A as in Apple, X is an X-ray, the number 2 at gmail.com. That's T-U, F is in Frank, A is in Apple, X is an X-ray, the number 2 at Gmail.
Okay, now let me say it back to you, okay? T is
Okay.
in Tom, U is in under, V is in victory,
No,
F
no,
is in, no,
no. T is in Tom, U is in under, F is in Frank.
oh, F, okay, F, and then A, and
Yes.
then X
Yes,
2, is that an FGN? 2,
It's-
F,
it's a T, U, F is in Frank, A is in Apple, X is an X-ray, 2, the number 2, and that's gmail.com.
Gmail,
Gmail.
gmail.com, okay.
Okay.
Okay, so down there,
Thanks, Bill.
okay.
You're welcome.